Today, we'll be looking at the principles, essential skills, and process of psychotherapy in cancer settings. Principles of psychotherapy in cancer settings. Now, psychotherapy is a structured process that helps patients or clients, as the case may be, overcome psychological distress, improve emotional regulation, and develop healthier coping mechanisms. So while different therapeutic approaches exist, several core principles guide effective psychotherapy across all modalities. So one of the basic principles is that of therapeutic alliance. And therapeutic alliance involves a relationship between therapists and the clients. It includes mutual understanding, agreement on therapy goals, emotional connection, and all of these allow for open communication that helps maintain the relationship, even after the deep sharing of experiences and feelings. So it is a relationship in which the patient considers that the therapist is competent and cares about him or her, or cares about his or her state. And it should be noted that a good therapeutic alliance is the main predictor of patients' compliance with treatment, regardless of the therapist's therapeutic framework or ethnicity or gender or any other characteristic. So once the patient and the therapist are able to connect beyond the surface, trust is built, then it's possible to continue to engage. So it's a necessary foundation for effective psychotherapy. Then a safe space. This is a setting which is defined as a place of healing. So a safe place is a place where the patient feels that I can get healing here. And it's a context in which the patient feels a sense of safety, that he or she can freely explore and express how they truly feel without fear of being judged. So there is that, it's a non-judgmental, it's a safe, non-judgmental space. And the patient is just able to say almost anything that they feel or their opinions, and they are rest assured that they won't be judged. And at that point also, in the safe space, the therapist provides active listening, empathy, and unconditional positive regard. And unconditional positive regard does not necessarily mean that we agree with all that the patient is saying or with their perspective. It just means that we respect them, we accept, not that we are in agreement, but it is their opinion, and we respect that opinion. So that's what unconditional positive regard is. And so part of creating a space, a safe space, may also involve defining the scope of the relationship to help maintain professional boundaries and to also help manage expectations. To also help manage expectations, while also ensuring and assuring the patient of confidentiality, collecting informed consent, and providing respect for the client's autonomy as much as possible. And so providing this type of safe space will help the patient to feel unjudged, will help the patient to feel heard, and will generally help the patient to feel safe within the therapeutic relationship. Then an explanatory model is also very important because it provides a rationale through which we are able to understand or explain the patient's experience and how it can be overcome. So the principle is based on the theoretical orientation of the therapist, and it provides the conceptual framework through which a plausible reason or some possible explanations can be made for the patient's symptoms and that can prescribe a set of procedures for resolving the problems as they become identified. Now, the therapeutic approach describes a set of procedures that the patients and the therapists both believe will lead to a restoration of the patient's mental health. And this therapeutic approach requires the active participation of both the therapist and the patient. And so, in other words, the therapist has a role to play as the expert in the different psychological treatment modalities, as the expert in understanding the theoretical frameworks by which these behaviors are occurring. The patient, on his part, is also an expert in understanding how the shoe pinches, in understanding what he or she feels as a patient, as the one experiencing the distress. And so it is in this understanding that each has an understanding of the roles they each to play. The therapist and the clients may collaboratively work, to provide solutions, but it's also the patient's responsibility to see that the solutions jointly provided are acted upon or worked on. And so to this extent, both the therapist and the patients or clients have active role to play in the therapeutic process. So the therapeutic approach involves the use of evidence-based therapeutic methods that are backed by scientific research and clinical effectiveness to help the patient overcome whatever challenge they may be encountering. And it often involves setting clear, measurable, and achieving goals that should be collaboratively defined and adapted as therapy progresses, with a focus on both short-term symptom relief and long-term psychological growth and well-being. It is important that as psycho-oncologists, that we continually update our knowledge and integrate these new findings into clinical practice. And one of the ways we can update our knowledge is attending conferences, going for trainings, and that is how we can be up to date with the range of available therapeutic approaches that can be used to help patients cope better with their illness. Adaptability and flexibility is very, very key in conducting psychotherapy in cancer settings. And adjusting therapeutic techniques could be based on clients' progress, their motivation, and the feedback that clients give in the course of sessions about how helpful or otherwise approaches or techniques have been. And therapy should be tailored to the client's specific, unique needs, personality, and cultural background, and may demand integrating elements from different therapeutic approaches for a holistic treatment instead of sticking just to one, right? So a single cap does not fit all. It all depends on what the problem is, how the problem is understood. And that will determine the different modalities that may be used. So practicing cultural competence and adapting therapy to diverse backgrounds and identity is very key. And so the role of adaptation and flexibility in psychotherapy in cancer setting cannot be overemphasized. However, when the effective implementation of intervention is hampered by strong patient-induced factors, maybe their personality traits or other issues that's happening around them, adjustment in the clinical evaluation and greater adaptation of the intervention package to patient needs should be made in consultation with colleagues more experienced in the field of psycho-oncology. So, characteristics of psychotherapy in cancer settings. Now, providing psychotherapy to patients with cancer require the therapist to adopt a flexible framework, right? As the basic structure of psychotherapy may be impacted by the patient's health status, especially when the patient's illness is advanced and when their medical condition and ability to adapt to engage in therapy may decline rapidly, so there may be a need to also adapt the therapeutic procedure to fit this. And then also there are times when patients' relationship with family and caregivers may be important consideration in helping the patient get better. There are times patients may ask the therapist to assist in communicating with family members, children, spouses, and others. And so the therapist should be able to widen the therapeutic contract to include family members in treatment. And this does not really mean that the form of therapy has changed from individual to family, but rather it's just an interlude. It's just something that becomes necessary for a particular reason, but it's not like it's for an ongoing basis. So, and so the therapist, even before involving the family, must first spend some time with the patient to clarify issues to be discussed in the family session and the depth of discussion that will be had. So it's about the patient at the center of the conversation. What does the patient want to achieve from the family meeting? And that would be addressed. So system issues related to usual routine or culture of delivering of care within the clinic or ward where the patient is receiving treatment may also impact structure of psychotherapy based on the level of disruption that is envisaged. If psychotherapy is done at certain times or certain places, with what kind of disruption will be caused within the clinic or ward setting if psychotherapy is conducted at certain times or certain places. And so this would also need to be considered in structuring psychotherapy. And so flexibility in therapeutic setting. And so we look at time. Time is something that can be very important in therapeutic setting. And usually in outpatient psychotherapy clinics or framework, there are specific time in a specific day where patients and therapists are supposed to meet. But in the case of cancer treatment, there may be a disruption in the time when patients meet, especially say in settings where there may be a need for crisis intervention, for instance. And so the regular appointment time may not be possible. And even with regards to the physical space, if the patient suddenly takes ill and is no longer ambulatory and has to be admitted in a hospital ward, or needs to change clinic, there will be a need to also change the physical space to accommodate this change that the patient has experienced. So either instead of coming to the office, the therapist may be the one to go either to the home or the clinic or wherever is more convenient for the patient based on their current condition to see. Also, the duration of sessions may differ. Typical psychotherapy sessions take 45 minutes to 1 hour. But in the case of oncology, this may differ from time to time, depending on the patient's clinical state or the kind of treatment the patient is receiving, or even the availability of time, how much time is available. And so the duration of a meeting should be established based on how much the physical health of the patient is affected, differing for a patient hospitalized in an intensive care unit compared to a patient following radiotherapy treatment. And so All of these could differ. And so the duration of a psychotherapeutic session may even vary from as little as 20 minutes, instead of the regular 45 minutes to 1 hour, it may be much less than that. And so that should be borne in mind. And so in terms of the engagement in the therapeutic process, patients with advanced illness may experience fatigue, they may be experiencing pain and other distressing symptoms that could interfere with their ability to concentrate and interact with the therapist. And so as a therapist, you don't have to shove therapy down their throat. No, all of these things are adjusted based on the patient's state of mind and interest at that particular point in time. And so patients may experience physical and psychological withdrawal progressively, or sometimes they may just lose interest in the content of the psychotherapy sessions. They may just not be interested. And so it is important that as psychotherapists, we are able to assess, and understand the context of this withdrawal, so that we can tell whether is this patient going through a depressive phase, or is it just a temporary loss of interest in therapy at that particular point in time. And so asking patients how they feel about their level of engagement or otherwise with therapy or with other people would also help in actually understanding the context of their withdrawal. Sometimes patients may just say that they are comfortable with their decreased level of engagement and are peaceful with it, or that they would like the engagement to be done at some other time. And so in that case, the therapist can be supportive by respecting the patient's opinion. At some other times, the patient may report wanting to do more, but feeling unable to do it. And that may, suggest the need for intervention, either pharmacological intervention or the use of behavioral strategies to help the patient at that particular point in time. So flexibility in therapeutic content and process. A diagnosis of a life-limiting illness will often create a heightened sense of awareness of the importance of time, both to the therapist and the patient. Time is often something of essence, and different themes would often emanate, during therapy. And so there are times when a therapist will come to the session with an agenda, with something they would like discussed, but the patient has a different agenda. And oftentimes is sometimes okay to defer to the patient's agenda, especially in times where time is of essence, time is limited, and different themes may come up. And theme of time itself as something that is being exhausted could come up, and with associated questions referring to or related to the cause of the disease may dominate a particular session. Other times, themes of loss, themes of regrets, themes of personal integrity, anticipated grief, themes of hope, themes of death are also themes that could come up recurrently within sessions. And at times we'll even be themes about troubled relationships that the patient would like to resolve and all of that. So it's important that we are flexible in terms of the content and process of psychotherapy in cancer setting. So psychotherapy provides the patient with a space where present, past, and future can be perceived either separately or jointly. We just allow the patient to sometimes, as therapists, we may need to just follow the leading of the patient in such a case. And patients can hold both awareness of probable or imminent death and hope for a cure. That's it looks like being able to simultaneously hold two seemingly opposing views, because there are times when these two seemingly opposing views can be true, right? Yes, death may be imminent, but right here and now, the individual is still breathing, the individual is still living, and the individual could have hope for the other parts, the rest of his or her life, no matter how long it is. And so sometimes as therapists, we ourselves must be comfortable with the theme of death and life as narratives that can co-occur, in the same thing. We should be comfortable with it, so that the patients themselves would be feel free to express themselves as much as possible. Then flexibility in the therapeutic relationship. So in the midst of illness narratives, the relationship with the therapist should bring a sense of stability and a safety in the patient's life, as much as possible. And with illness threatening many aspects of life, including the very sense of body integrity and survival, the stability and predictability of the relationship with the therapist can promote a sense of hope. But there are times when issues arise in form of transference and counter-transference, right? That may be problematic to this rather emotionally stabilizing relationship. These can be safely handled by skilled psycho-oncologists, or the need for supervision meeting with a lead psycho-oncologist may be indicated to ensure that the therapeutic relationship is preserved. In extreme cases, there may be a need for patients to be seen with by another psycho-oncologist if the counter-transference appears impossible or difficult to resolve. But in most cases, it can be resolved with appropriate supervision, where psycho-oncologists may be struggling with these issues. Then termination of therapy. The end of treatment is a crucial and delicate part of every therapeutic relationship and process. Psychotherapy interventions based on time-limited approach may be more likely to offer both patients and therapists the opportunity to review the work done and to say goodbye, thus openly acknowledging the end of the therapeutic relationship. And oftentimes, even say 3 to 2 sessions before the last session, therapists will have been preparing the mind of the clients that therapy will soon come to an end. And, there's the processing of emotion with regards to the therapy ending, right? But in the case of cancer treatment, this is not often the case, because sometimes therapy ends abruptly, right? Therapy ends abruptly sometimes. And so this may not often be the case in cancer setting. So, so the patients, for instance, sometimes patients may die suddenly, or they may be transferred to a different facility. So this has a way of impacting both the patients and the therapist. And the ability to effectively direct or process the end of therapy with the cancer patient challenges the therapist's clinical experience, judgment, and intuition, right? And so one of the approach that may work is looking at every session and assessing as if, there won't be a next, because we can't always predict whether there will be a next session. And so dealing with each session, trying to assess each session and, summing it up until the next time. And so while the awareness of the progressive decline of the patient's health may prompt therapists' desire to begin saying goodbye to the patient, clinical experience suggests that this process should not be started or imposed on the patient who is not ready. And so if the patient appears unwilling or unable to share any negative emotions related to the end of the relationship, the therapist should respect this choice and accept it as it is. However, the therapist may express his or her feelings, modeling the expression of emotions for the patient. The patient may or may not choose to follow the therapist's implicit invitation to share feelings of sadness. Thus, for example, a therapist may gently raise the issue by saying, I have been thinking about what it would be like for us to say goodbye at the end of the session. The patient may decide to accept or ignore the invitation, and it is essential that the therapist respects this patient's boundaries. In this context, termination, whether due to the end of therapy or to the end of the patient's life, must follow the same principle of preserving the integrity of the patient's emotional life, safeguarding him or her from suffering and from emotional distress. And so for me, something I just do is I deal with every session, as conclusively as possible. And I invite the patients to talk about how useful, the session has been for them in dealing with whatever issue that was brought up in the session, right? And then we talk about the possibility of having another session based on whether the patient is discharged or transferred to another clinic or whatever, as much as possible. And so, it can be termination of therapy can sometimes be challenging, but it takes that's why the therapeutic alliance is very important in the first instance, and that can help build, can help even lay the foundation for when therapy would be eventually terminated. And so we'll move on to the essential skills of psycho-oncologists. A psycho-oncologist plays a crucial role in the psychological and emotional well-being of cancer patients, their families, and the healthcare team. And so the field of psycho-oncology integrates psychological principles with oncology to support patients in coping with the challenges of the cancer diagnosis, treatment, and survivorship. And so it's important that we look at some of the essential skills that a psycho-oncologist should possess for them to be effective within the oncology space. So first and foremost, the psycho-oncologist must have assessment and counseling skills. And so there must be that proficiency in using standardized tools to screen and to evaluate emotional distress, anxiety, depression, adjustment disorders, and other psychosocial or spiritual problems or issues that cancer patients may confront. And they must also be skilled in conducting both individual and group forms of counseling. Communication skills is also very key, as effective communication is at the heart of empathic listening to understand patients' concern and delivering difficult news sensitively and supportively. It's also very important in educating patients and families about coping mechanisms and treatment options, as well as in collaborating with oncologists and medical teams to ensure holistic care. So every psycho-oncologist needs to build communication skills. If it seems not to be lacking, there's need to attend communication skills workshops to be able to, develop those skills. We are not born, not everyone is born with these skills, but these skills can be learned and should be learned to work effectively in the cancer space. Then crisis intervention and coping strategy skills. Psycho-oncologists must have crisis intervention skills as well as coping strategy, even personal coping, and for the patients too. Managing acute emotional distress, panic, and existential crisis. And this skill is also important in helping patients develop resilience and to adjust to change in their life roles, teaching relaxation techniques, So all of these coping strategy techniques are very important and should be at the fingertips of the psycho-oncologist. And then there is also the need to acquire knowledge of oncology, the medical aspects of care, in terms of understanding the cancer biology, the different treatment modalities, and their possible side effects. And that would give an understanding, help the patient, and help the therapists will be able to help the patient to normalize certain experiences without minimizing their importance. So patients' emotional responses are significantly impacted by the stage of the disease at time of diagnosis and the availability of disease-modifying treatments. So the ability to recognize the psychological implications of each phase of illness, as well as those related to various types and sites of cancer, will enable the therapist to meet patients and families' evolving needs. It will help them to be able to explain certain things to them better or develop coping strategies that are apt for those situations, for those patients. For example, patients with pancreatic cancer, are often found to experience depression related to the disease and the chemical changes that occurs in the brain and the system, the hormones, because of that disease itself. Similarly, head and neck cancers can have profound negative impact on patients' self-esteem due to the disfigurement that frequently follows treatment. And so having this understanding helps the psycho-oncologist, prepare the interventions to help patients deal with these issues. So therapists should also be familiar with the range of potential medical interventions at different stages of the illness. This knowledge will allow the psycho-oncologist to function as effective members, members of the healthcare team, and to be able to fully understand the patient's concerns, assess their understanding of their medical condition, and support them in decision-making process regarding treatment. And so there are times when patients may be catastrophizing about certain symptoms or the stage of their disease. But because the psycho-oncologist has an understanding of this, they are better able to support the patient in whatever level they are in. Then cultural competence and ethical sensitivity is also a very important skill that psycho-oncologists need to have, because it is not enough to simply apply Western psychotherapeutic approaches to culturally diverse patients like ours, without a good understanding of their background and worldview. Such kind of stance, such kind of approach will be counterproductive. And so therapists' ability to negotiate these differences without minimizing or trivializing them is often crucial in determining whether patients will continue treatment. And from another stance, another perspective is that even when patients and therapists belong to the same racial or ethnic group, their personal worldview is shaped by unique elements such as family and community, as well as spiritual and religious beliefs. Therefore, psycho-oncologists should be skilled in thoroughly exploring the patient's worldview, the patient's explanatory model for the illness, and the specific cultural elements that may affect decisions about medical treatment. There is need for therapists to develop both generic and specific cultural competence depending on the population that they work with. And so generic competence just refers to qualities and skills that are necessary anytime a therapist works with a patient, whether from same or different cultural background with a therapist. A therapist who develops generic cultural sensitivity will not assume that apparent similarities in cultural backgrounds necessarily translate into similarity of values and practices. There is always that part about individual differences, individual preferences, and all of that. But specific cultural competence, on the other hand, refers to the therapist's knowledge and understanding of the particular culture to which the patient belongs. The ways in which patients integrate a cancer diagnosis, make meaning of their diagnosis, and conceptualize how and why the illness was developed is culturally determined. A sense of curiosity, freshness, and deep respect for the patient's cultural values and practices will allow the therapist to promote therapeutic alliance and increase the likelihood of obtaining positive outcomes. And so sometimes it's not even out of place to try to ask people from a different culture or to ask other people from a different culture or similar culture with the clients that we are not familiar with, or to read up about those other cultures and their perception of illness and all of that, to give us a brief understanding. But most of all, it's always better to obtain the patient's perspective, putting the patient at the center of the entire process. Then there should also be that skill of multidisciplinary collaboration. Now, psycho-oncology is a multidisciplinary field. And oftentimes when cancer patients come for treatment, different professionals treat them, including the primary oncologists, the nurses, the social workers, the palliative care team, and on and on. And so there must be a form of multidisciplinary collaboration. And this skill is very, very important. A skill that the psycho-oncologist will need to have, because the psycho-oncologist will need to liaise with other professionals to be able to give this patient a holistic care, right? And to be able to, have a holistic perspective of what is happening in this, within the patient's life and in the context of the medical treatment and outside of the hospital setting. So, and this will facilitate supports for support groups and family interventions where this is important. Then research and advocacy skills are also skills that a psycho-oncologist should possess, because conducting research on psychosocial aspects of cancer would help, would generate data that could be very instructive in clinical practice. And advocating for mental health support in oncology settings as much as possible, because we do know that in most oncology settings, mental health support is meager. And so there's a need to advocate more. And so having advocacy skills becomes very important, and especially the skill of engaging with policymakers to improve patient-centered care. The skill to maximize the potentials of an existing system, instead of trying to change it. Oftentimes, it's difficult to change how a system runs, or to change how much resources a system may make available for psychosocial oncology practice. And so psycho-oncologists often work within an established healthcare system that would often demand that he or she optimizes patient care and mental health support without necessarily altering the system structure. And so this skill may require that the psycho-oncologist work with interdisciplinary team of oncologists, nurses, and social workers to develop shared goals and to harness available human and infrastructural resources to seamlessly incorporate psychological interventions into existing medical workflows. And this will ensure that mental health care is available and is provided, for cancer patients without necessarily requiring systemic change. Also, there may be a need to also use training of medical staff to carry out basic psychosocial care, and so that way patients have access at least to some sort of emotional support, even as they navigate their journey. And so every system has its way, but the psycho-oncologist must be skilled in identifying the potentials available within the system and understanding how these potentials can be harnessed to achieving the goal of patients having access to psychosocial oncology care. So next, we look at psycho-oncologists on helpful assumptions. Psycho-oncologists on helpful assumptions. Now, based on clinical experience working with cancer patients, it can be very easy for new psycho-oncologists to adopt ineffective attitudes or beliefs that may make it difficult for them to work towards properly supporting the cancer patient. And so we'll look at some of these assumptions that may be unhelpful with cancer patients. And one of the assumptions is that the patient must reach deep insights, that counseling is only successful when the patient gains insight and is fully adjusted. In cancer care, success is not only about having complete adjustment or developing deep insights about one's condition, but it's more about helping patients cope in ways that work for them. Some may never fully adjust to their diagnosis, but they can still experience improved quality of life and emotional relief. And so it's just important to not judge yourself as a psycho-oncologist, as being inept, as being not effective, just because patients are not showing that they have gained deep insights or have fully adjusted to their disease. No, this process can be gradual, right? Yeah, so it may not be in terms of fully accepting the diagnosis, but experience of quality of life, emotional relief, are also indices of a successful therapist-patient interaction. And then patients, sometimes there's an assumption that patients are psychologically fragile. And because we assume that patients are fragile, it makes us to walk on eggshells around them, avoiding certain topics, right? I'm using the paternalistic approach, and that's what often gives birth to those issues like wanting to protect the patient from bad news. I put that in quotes, and things like that. So when we assume that the patient is fragile, it may lead to us being overly cautious or having patronizing interactions, which are not really authentic with the patient. And many cancer patients, however, show remarkable resilience, and they prefer to be seen as strong rather than fragile, right? And so sometimes patients, also psychologists may assume that solving practical problems or practical matters is not counseling. However, problem-solving strategies and approach to addressing practical concerns that may be related to finances, treatments, logistics, family issues, and the like, whatever it is that causes significant distress. So addressing these concerns can be therapeutic, reducing stress and improving emotional well-being. However, where some of these challenges may come up is where, for instance, the patient needs money for treatment, and it seems like the therapist, I mean, like in our setting, the therapist may be feeling like obligated to provide this money, or to ensure that this patient gets this money. And that is why it's very important to define the scope of the relationship, right? At the very inception, describing the scope of the relationship, so that the therapist does not become unnecessarily, begin to feel guilty because he is unable to provide solution to the practical needs of the patients. One way is providing referrals, right? It's an intervention. Providing referrals to community resources like non-governmental organizations, providing referral to the social works. All of these are issues. And there are times where you can also provide practical advice to help in this matter. I remember there was a time I had an interaction with the mother of a pediatric cancer patient. And her problem at that point in time was not money, but she had a young baby. And the other child she was caring for was paraplegic because of the spread of the cancer. And she had to also back the older child to the ward. And so she was wondering, she is a visitor in Ibadan. And so she was wondering what she could do, how she could cope with that. And so I simply tried to identify where was she living, what are the available resources in terms of daycare centers in that vicinity. And that solved that problem for her. And so the therapist solves that problem that he or she can solve, and then make appropriate referrals to others. But problem solving, where possible, is an important part of counseling. Then avoidance and denial are unhelpful or are bad. That assumption that when patients avoid or when patients try to deny the experience of their cancer experience, sometimes we assume that this is bad or is maladaptive. But psychotherapy for cancer patients, and indeed for anyone with serious and advanced illness, necessitates providing a literal and symbolic container where hopes, opinions, uncertainties, fears, and anxieties can be safely expressed by the patient. However, during a psychotherapeutic relationship, patients may never say the word cancer or death. They may not want those issues to be discussed or to be brought up. And this, may appear as a form of denial or avoidance, but it's not necessarily so. And so psychotherapists would be interested in gently exploring the patient's level of awareness and how their decisions to talk or not to talk about the disease, or their choice of certain words or phrases instead of conventional ones, are supportive or unsupportive of the patient's therapeutic process. So an important aspect of psychotherapy with cancer patients, like we keep saying, or like I've been saying, is preserving life. In other words, it refers to safeguarding the patients from psychological harm so they can cope with the illness, fostering healing and growth in whichever way that works for the patients. And so some patients may exhibit self-directed disclosure or acceptance, where they may have an internal and clear awareness of the severity of their prognosis, and at the same time choose to not discuss this awareness in explicit terms. In some cases, denial and avoidance may serve as a protective coping mechanisms, allowing patients to process their situations gradually. And so something we should ask ourselves sometimes is, if I remove this denial from the patient, with what coping strategy do I hope to replace it? Right? And so there was a patient once that I had an encounter with, and the patient had cervical cancer, but she was okay saying she had ulcer, right? So she said she had ulcer. But the important thing is, that is how she could cope. She was in the department receiving her radiotherapy, receiving her chemotherapy, which is all well and good. And so it is not okay for us to push for full acceptance too soon, because that may overwhelm rather than help the patient. The patient's general predisposition to life and care in terms of self-care and treatment adherence will tell if this denial or avoidance approach that is being adopted is adaptive or maladaptive. And then sometimes also we have this unhelpful assumption that depression and anxiety, that when cancer patients are depressed or anxious, that it is negative. Well, let me just say here that these are emotions. Anxiety, for one, all of these emotions are emotions. They are there. Emotions are natural, and they are responses to what may be occurring within the patient's, within or outside of the patient. It's how the patient is responding. And so these emotions are there. They should be acknowledged. They should be validated. Why? Because while these emotions may appear challenging, distress may be challenging, experiencing anxiety or sadness is a natural response to a life-threatening illness, right? And so instead of trying to eliminate these emotions, therapy is meant to explore the emotions and to help the patient manage the emotions constructively, place the emotions in context, because sometimes what is causing the emotion may be cognitive distortions, maybe misunderstanding of certain things that are happening in the patient's life. And so trying to understand the patient's perspective and realistically helping the patient to guiding the patient towards seeing a more adaptive way of dealing with it. And so while expressing distressing emotions may be uncomfortable, but it does not necessarily mean it is inappropriate. Sometimes these emotions may appropriately fit the situation, but there's a need for patients to be helped and guided on how to develop strategies to cope and manage the emotions. So another assumption that patients must go through certain adaptive phases. It's problematic, as not all patients follow a predictable emotional trajectory. You know, like the type proposed by Kubler-Ross's stage of grief, where the patient moves from denial to anger to bargaining to depression and then finally to acceptance. Sometimes patients do not go through this trajectory strictly. And so people cope in diverse ways, and we should avoid forcing a linear model that may validate the unique experience that each one has, to cancer. And finally, and by no means, it's not exhaustive, assuming that dying is the worst thing that can happen. As much as possible, as psychotherapists, we want to normalize normalize death and the dying process, because life and death are on a continuum. And so we should not make patients feel like or wholly agree with the patients that dying is an entirely bad thing, because death and life are on a continuum. There's a time we start and there's a time we end. And moreover, many patients prioritize quality of life over longevity. So some patients, they rather have a good quality life than live forever. And so as much as possible, we as psycho-oncologists must first be comfortable with the concepts of death and dying, for us to be able to address the issues that come up in this regard. And so with some patients, finding meaning and peace in their final days and framing death as the ultimate failure may undermine their emotional journey. And so let's work towards building, aligning with the patient's adaptive perspective to death and dying, and not complicate it. Yeah, let's align the adaptive aspects. Okay, so delivering and adapting psychological intervention in cancer settings. Well, in cancer settings, different formats have been used for delivering psychological interventions, including individual therapy that involves a face-to-face or, so when I say face-to-face, I mean whether in person or online. And sometimes it could be even a telephone call, all right? But it's one-on-one, the therapist and the client or the patient in therapy. And then with group therapy, it involves 6 to 12 persons with a facilitator, 1 or 2 facilitators in therapy with the group. And oftentimes groups are developed, groups could be heterogeneous or homogeneous. And so when they are heterogeneous, that means that the patients have different forms of needs or different types of cancers, different gender, different stages of the disease. It could even be both a caregiver and a patient group, right? Oftentimes such groups work for providing information and things like that. But effective groups are like psychoeducation, that could work for them, especially if the information that is being provided is equally beneficial to everyone present. But there are some specialized groups that are homogeneous, maybe based on the type of cancer or the stage of cancer, based on gender, or based on the stage of disease. So there is a common theme that is bringing all of these patients together, hence homogeneous groups. And so discussion will be around common themes that all patients in that group would usually experience. There could also be groups where at any point, anyone can drop in or anyone can drop off, right? And there are some other groups that are more closed groups where patients start at a point. Maybe it could be a 4-week long group session. It could be 12 weeks. And so once patients start at week 1, no other patient can come in until at the end of week 12, and the new group is to be developed. So there are different forms of rules that govern group therapy depending on the type. And sometimes there are support groups, therapeutic groups, support groups. Generally, the number of groups, people in groups should be like between 6 and 12. Normally, also depending on the number of facilitators that are present. And when groups are too small, it limits diversity in terms of perspectives and sharing. And when groups are too large, it could also have impact in terms of reducing individual participation and emotional connection within the group. So couples and family therapy are also germane. There are times when couples, before the cancer diagnosis, they may already have been experiencing problems, and some may experiencing problems after therapy. After the cancer diagnosis. And so this may call for couples therapy. It may relate to issues of sexual dysfunction. It could relate to fear of being, fear that cancer may be contagious. So all of this may indicate the need for couple and family therapy, as the case may be. And of course, therapy can be virtual or it can be physical, and there are different types of mental health intervention that are available right now and can be very beneficial for patients who are not ambulatory or patients who are in rural settings where therapists may not be readily available. And so being able to connect virtually may help such patients to access care. And interventions can also be customized to patients at different stages of the disease. For instance, those who are recently diagnosed may be dealing with issue of shock, denial, fear, anxiety, and uncertainty. And interventions at this stage are meant to help develop crisis intervention or coping strategies to help patients deal with these issues, as well as support them during decision making in terms of seeking second opinion or the treatment of choice that they would engage in, as well as promoting effective communication between family members. During active phase, interventions may be focused on addressing response to treatment, anticipatory nausea following chemotherapy, dealing with anxiety and all of those treatment side effects, and this feeling of loss of control that may come with cancer treatment. Then sometimes patients that are in total remission or in partial remission may experience fear of cancer recurrence and may have identity and role adjustment issues to deal with. And all of these are important in survivorship, helping them adjust to the new normal, helping them deal with life after cancer treatment. Then patients with recurrence, because sometimes recurrence happen, and patients may, have emotions related to feelings of hopelessness, fear, anger, grief, loss of trust in treatment, right? May even develop fatalistic attitude. And all of these are important focus for treatment. And then at the terminal stage or end of life, patients at end of life may be afraid, may have issues with existential distress, some may have peace with the prospect of dying, and some may be anxious about that prospect. And so these also have certain interventions that are really focused to them, like interventions related to finding meaning, developing, having a form of dignity, talking about the concept of good death and bad death, and having support, for the family. All of these are interventions that could come up based on the stage that the patient is at any point in time. So, as much as possible, psycho-oncological interventions should be flexible. This cannot be oversaid, and patient-centered and aligned with emotional, cognitive, and existential needs of each phase of the disease. The general goal of the principles and the skills we have in psycho-oncology is to help reduce distress, to enhance coping, to promote the best possible quality of life for our patients at every stage.